Today what I'd like to do is an overview of MECFS. I'm assuming that everyone here has a certain degree of exposure, but it's probably very heterogeneous exposure. Some of you are probably great experts and you've read everything and know everything, and some of you are kind of confused about what it is, and so therefore I'm going to try to go over the basics, but at the same time be able to throw in some sophisticated stuff for those of you who are not rookies. MECFS is what many people call this, although that's been so controversial, and it stands for myalgic encephalomyelitis / chronic fatigue syndrome. Lots of arguments about whether or not these are two separate diseases or one illness. My bias, and I'm stressing that this is a bias because it's very important. Everybody who works in this illness has a bias. And mine is that I was a town doctor in the town of Lindenville, New York. Actually, I trained in pediatrics and in pediatric chronic disease. And you know, I gave that up and became a town doctor. And in October 5th, 1985, I saw a couple of kids who had mononucleosis. That week, I saw 8 kids who had the same thing, and it looked like regular mononucleosis. They had severe sore throat, lymph node tenderness, lymph nodes here, muscle and joint pain. They were exhausted, they couldn't get out of bed. And of those 8 kids, 4 were girls in one family and 4 were boys in the other family. And it turns out, after a week or so, I went and I made house calls because one of the girls was, or all 4 girls were daughters of my office manager, and she told me to go to something better. But I went and I saw them and I said, oh, it's just run-of-the-mill mono and they're going to get better just fine. And after 2 weeks, none of the 8 got any better at all. And my wife was an infectious disease specialist. We scratched our head because mono doesn't go in clusters like this. And we started studying. We were able to easily prove that none of them had Epstein-Barr virus mononucleosis. They, you know, their antibodies were clearly not that. And now 30 years have passed, and one of my first patients, the first kid that I saw with this, daughter of my office manager, she just came to my door with her 13-year-old daughter, and her daughter has it. And for 2 years, they've been trying to find a doctor to take care of her daughter. And they've been to every specialist in Buffalo and in Rochester, and everybody says, oh, it's just, you know, who knows what it is. But this is not something that is an occasional illness. It runs in families, and it runs strongly in families, and it's a disastrous illness. So one of the things that ETEL is committed to is to try to get some research going, to get awareness, to get funding. It's really a tragedy. I've taken care of over 50 people who have been bedridden. Now, because I live so far away from ETEL's son, you know, I'm not really taking care of him. I saw him in a consultation, but I've seen or taken care of 50 kids and adults who were bedridden, and nobody knows about this. So anyway, that's my bias. If you brought in, or if in November of 1985, I brought in 10 different specialists, one who was a fibromyalgia specialist, one who was an orthostatic intolerance specialist, one who was a chronic Lyme specialist, one who was whatever. They would all diagnose about 10% of this cluster as having what's in their specialty. Now, Lyndonville is a very small town, halfway between Rochester and Buffalo. Very little communication with either Rochester or Buffalo. It's rural. You know, there are orchards and fields. Everybody has well water that's polluted with uranium and everything else. But it's a very isolated community. Whatever happened there in 1985 was one thing. That's the only thing I'm positive of. You couldn't have you know, 5 different epidemics come in at the same time, all with similar symptoms. So my bias is, and I freely admit it's a bias, is that this is one thing that happened in Lyndonville. I published a paper, 86 or so, saying that 75% of my pediatric patients with this illness also met criteria for fibromyalgia. And so, are they different diseases? Maybe, but I don't think so. You know, my hunch is that if you get chronic fatigue syndrome, the first 5 years is concentrated on fatigue, and then from then on, it gets more and more pain. It's, again, just a general observation, but I don't see these as being vastly different illnesses. Okay. We don't need to go over this. This is not a CME lecture. Recently, the National Academies came out with a book where they looked at 9,000 different studies, and they really did some hard work trying to redefine this illness, come up with something. Now, this is a very important thing because the National Academies and the Institute of Medicine, nobody can say that they're a bunch of jerks. You know, I'm a country doc. You know, who knows what that guy, that weirdo, is saying. But the Institute of Medicine, nobody can say anything against them. They are good. And they have said in this report how important this disease is. And it really is incredibly important. Primary message is that it's a serious, chronic, complex, multi-system disease that dramatically limits the activities of the affected patients. And that's the central message. Because it affects the activities, they are calling this SEID, Systemic Exertion Intolerance Disease, meaning that people with this illness are intolerant of exertion, any exertion. Now, there's a huge variation in severity. So some people cannot tolerate the exertion of standing up for 5 minutes. It sounds impossible, but you know, we would always test that on the first visit. We'd have people stand still for as long as they could. And healthy people can stand 90 minutes, no problems. People with this illness, 5 minutes, 10 minutes, 15 minutes, occasionally 40 minutes. But exertion intolerance is perhaps one of the central issues, and that's why they recommend calling it SEID. Now, so far, that name hasn't caught on. At least 1/4 of the patients are either housebound or bedbound at some point in their lives. And that is amazing. Now, this is a study that was done 2006 by the Center for Disease Control and the Australian government. And I think it's the most important study that's ever been done in MECFS. Because what they did is they took this little county in the middle of Australia, Dubbo, and they found every physician there, and they enlisted them to report anybody that came into their office with either Epstein-Barr virus, EBV mono, or Ross River virus, which we knew also set off ME, and 65 patients with Q fever. And then they did extensive testing on these patients. They tested them right then on day one when they came into the office, and they tested them every, I don't think it was 6 weeks thereafter. At 1 year after they came into the office for the first time, they asked the question, do you fit the criteria for chronic fatigue syndrome, the Fukuda criteria of chronic fatigue syndrome, which has about a 50% reduction in activity. And this is at 1 year after the onset of whatever it is they had. Now, the results of the study were fascinating. At 12 months, 6% met the criteria of chronic fatigue syndrome. And that's not that exciting. It's interesting, but not that exciting. What's exciting is that 6% of EBV patients, 6% of Ross River virus patients, and 6% with Q fever all came down with chronic fatigue syndrome. This is an illness that can affect 6% of the population if you get the right triggering infection. So EBV, Ross River virus, and Q fever happen to be infections that triggered this illness. And we know of lots of others. There are many different infections which will trigger it. I've had patients who had psittacosis and histoplasmosis and a number of other things who, after their infection was treated and cured, they didn't get better. They stayed or persisted with chronic fatigue syndrome or ME/CFS. So in my mind, the most important issue is not what was the thing that set it off, but what is the 6% that people never knew that they had? Lots of little hints about what's going on with the kids prior to their getting sick, but they stay pretty well up until age 10, 11, 12, 13, puberty, and then they get sick with ME/CFS. I mentioned the daughter of the office manager, her only daughter was well until puberty, and then she got sick as well. So is it a genetic thing that affects 6%? Is it an underlying two-hit infectious thing? Nobody has a clue. Isabel here is going to figure it out, and I'm very happy about that. But nobody knows, and unfortunately, there are very few people who are even looking at this 6%. Everybody's arguing about, oh no, this is caused by EBV. No, I had it from Ross River virus. Doesn't matter, it's the same illness. Now, the other thing that's very important about this study is the most important predictor was the initiating infection severity. So if in the first month of this illness you were bedridden, you're stuck with ME/CFS for the rest of your life. Now, it can be mild. It can be so mild that you can lead a normal life, but you're not going to get better. You're not going to be cured. If in fact it wasn't that severe, you know, you still could, if you were a kid, you could still go to school every day, but you just didn't feel well. But yeah, good chance that it's going to go away. Now, most people say that, oh, I got sick at age 37. But I would bet that if those people look at their past histories, they would say, you know, I had mono when I was 16 and I was sick for 2 years with mono. Does this story resonate with anybody here?
Not mono specific. I had mono, but other symptoms. I missed 2 months of school.
But a lot of people will have some initiating infection as a teenager, and then they get better, only to get much worse again at the age of 35, 40. The second thing about this that was incredibly important was that emotions were not a predictive factor. Psychiatric studies done in this particular study showed that these were normal people. They were not ones predisposed to emotional illnesses. So, premorbid psychiatric status, in my opinion, has nothing whatsoever to do with the severity of the illness. It does have to do with how much of a complainer that person might be. So if somebody was neurotic their whole life and came into the office, we had a sign right over the door that says, no whining except for the first 10 minutes. So first 10 minutes, yes, you can whine, get it off your chest, but then that's it, no more whining after that. Okay, these are infectious agents that are known to initiate ME/CFS. And if you're a student of the history of this illness, you know that people are still arguing about whether or not they got it from HHV6 or parvovirus, Inuit-Melnick virus, coronavirus, Lyme disease. You know, is there a chronic Lyme disease? Every Lyme disease specialist says no. The Lyme organism goes away. Now, half of the audience is going to get up and walk out now because this is such a contentious issue. My personal feeling is that Lyme is an infection that can initiate the illness, but then the Lyme organism either disappears or is cured by the innate immune system, although people stay sick. And you can't find living Lyme organisms when you search for it. Now, lots of arguments, disagreements about different lab tests, but I see Lyme as one of the initiating infections and not a separate or a different disease. Now, I'm more than happy to, 3 years from now say, oh, I blew that one. You know, Lyme is a different disease, and I'm sorry for that. But at this point, when people would come to my office and they said, oh, I have chronic Lyme disease, and I go through their symptoms and their course and all of these things, I didn't find it much difference. Okay, this is where I'd like to start with what's going on with this illness. Somehow, there is an infection which initiates in 6% of the people something which we're calling ME/CFS. Now, that may or may not be true, but I think that it is true. And that's that 6% from the Dubo study. What it is that we're calling ME/CFS can be broken into 4 symptom clusters. And these symptom clusters, I've been struggling to find out how they're connected to each other because they all start right at the beginning of the illness. One of them is abnormal immunology. Now clearly there must be abnormal immunology here, but I'm not counting that at this. So for this, we have abnormalities in the natural killer cells. We have abnormalities in, before we get to that, the cytokines are what cause the symptoms of ME/CFS. Cytokines are cellular proteins that communicate and cause other things to happen. If you have influenza, you get an initial viral infection. Let's say you're in the supermarket Saturday afternoon, person next to you in the checkout lane has flu. That person coughs on you and you breathe in the flu virus Saturday afternoon. From that point on, you have the flu, but no symptoms. You feel great Saturday, Sunday, Monday, but then Tuesday afternoon, 3 o'clock, you suddenly get the flu. You get the chills, you get this, you're exhausted, you're nauseous, you have a headache, your muscles and joints ache, and you go to bed. You have the flu. But those symptoms are not due to the virus. The virus has been going like crazy for several days. Those symptoms are due to the cytokine response. your body now understands that you have a viral attack going on, and it puts out cytokines. The cytokines do wonderful things. They cause the temperature to go up, they cause all sorts of things. But cytokines are normal body responses and don't cause tissue damage for the most part. And then, you know, you go to the doctor says your exam is normal, you must have the flu. The symptoms are still there, and it's due to the cytokines. Your immune system eradicates the influenza, and the cytokines shut down, and you get all better. And you go back to work, and it becomes forgotten. In ME/CFS, the same thing happens, except the cytokine response does not shut down, and the symptoms persist indefinitely, you know, for years and years and years. I have patients that have now been sick for 50 years, and you know, their cytokine responses are still abnormal. This is a very nice study done by Mady Hornig, and what she says is that you can measure what's called an immune signature for 3 years after the onset of ME/CFS. Very specific immune cytokines, both pro-inflammatory and anti-inflammatory. Now these get really complicated, but her study is a very impressive study, and she says that someday when somebody gets sick with the flu, you can take a blood test, measure the cytokines, lots of them. She measured 51, and be able to tell whether or not this was the beginning of ME. We'll know probably in 25 years whether she was correct. So don't hold your breath. But this is the immune signature. So something is wrong with the immune response that doesn't shut down, which causes the symptoms to persist. It is my personal feeling that the cytokine changes in ME/CFS may be irreversible after a certain period of time, even if you treat it aggressively with the right things, which we really don't know how to do yet. Other areas of immunology which are abnormal, decreased natural killer cell number and function, 2,5-A synthetase, decreased gamma interferon, increased B cells, defective cell-mediated immunity, a whole bunch of things. And these are all immune abnormalities which we can argue about, but are basically part of this illness. So that is this area. Another area, and I see it as a completely different area, and one of the questions that I'm going to put out is, why is it that we get these different areas? The second area is an abnormality in the cerebral blood flow, and not just cerebral blood flow, but body blood flow. People have very cold hands and cold feet. If you accurately measure their circulating blood volume, 80% of them will have a reduced circulating blood volume, which can be dramatic, can be 50% of normal. And this happens to be the area that I wasted my career in, studying it like mad, because if you get in a car accident and you lose 15 to 20% of your blood volume at one time, it's fatal. And I had people who were walking around, not well, but had ME/CFS with 50 to 60% of their circulating blood volume. And you can't tell unless you do a proper blood volume exam. Now, the guy who invented the best test for this, he was a fellow in a town north of Boston, and I sent him the results from my first 10 or 15 patients. And I think I almost killed him because he had never seen anything like this. He said, no, that's impossible. But he actually verified it. He repeated the studies on the number, and he was getting the exact same results. Now, normally, when you do a blood test out of the arm, you get a hematocrit or a hemoglobin. That has nothing to do with blood volume. That is the proportion of red blood cells to plasma. But you can't make any guesses about blood volume from that. What the blood volume test does, you take a tube out and you take the red cells out of that tube and you label them with chromium-51. Then you inject that blood back in so that the patient is getting his or her own blood cells injected back in, but they're now labeled with chromium-51. After an hour or 2 hours, it circulates around the body. They take a blood sample and measure the chromium in it, and they can calculate very accurately the circulating blood volume, which is how much blood do you have in your body. The other way of doing it is to chop off somebody's head and pour all their blood into a bucket. I never have done that. But the blood volume is something that is incredibly important. There was an astronaut who spent 6 months up in the space station, and she came back and she was asked to give a short talk at the podium. So she was at the podium, and after 2 minutes, 3 minutes, she keeled over. And her blood volume was 82% of normal. Now, when you're in a no-gravity situation, this can happen, but usually you get a volume of about 82% normal. And everybody was shocked that she was so ill after coming in. No, she wasn't ill. She just had a lower blood volume by a titch. People with ME/CFS, they have big-time lowering of the blood volume. So basically, I spent 15 years, along with a couple of other people, asking the question, why? And there are many different things that control the blood volume. If you have a car accident and lose 20%, you put out massive amounts of antidiuretic hormone, and it comes back to normal. The antidiuretic hormone in this illness is not quite normal, but almost. So that's not the answer. And everything that we looked at was pretty good. It was pretty normal. It was functional. So what caused the low blood volume? I was at a talk just like this one, 20 years ago, and I said, nobody has any idea. This guy raises his hand, and he says, well, it's got to be that the pipes are too small. That instead of pipes this big, they're this big. And when you add that all together, you'll see that the blood volume is reduced. And I had one of those moments, and I said, are you a physiologist? No, I'm a plumber. And sure enough, he was right. Something in this illness, and it may be antioxidants or oxidants, it may be, I have no idea what it is, causes the blood vessels to decrease in size or to shunt. And that means that instead of going where it's supposed to go in the brain, it goes to the organs that are preferred, heart, lungs, and kidney. The brain doesn't count. You know, from a evolutionary point of view, brain is unnecessary. But heart, lungs, and kidneys are necessary. They get reasonable flow, but the brain does not. I just saw in the newspaper that the post-concussive syndrome is caused by decreased blood flow in the brain. That when you hit the brain, the jarring, whatever it is, will cause a change mediated through cytokines that reduces blood flow, and you can measure it 1 week after the concussion. And people are taking that very seriously. Those of you who are here who have ME/CFS, if we were to measure the blood flow in your brain, it would be much worse than boxers. And people potentially say you're just wrong. So I'm hoping that someday that gets looked at. There are other things that will cause the reduced cerebral blood flow. This is the blood volume Normal, the plasma is here. This is a bucket of blood. The plasma part is right here, and the red blood cells are here. In a person with anemia, they have a total blood volume which is just fine. Right here, same as here, but it's mostly plasma. And if you did the chromium-51 test, you would find this, just low blood volume. And that was treated routinely by blood transfusions. And it was very effective. People did very well. I've had one patient who had a blood transfusion, and that was followed then by 6 more, and she did fantastic. She was bedridden for years, had been an intensive care nurse, but with the blood transfusion, she went back to full-time work and was able to continue with that until her hematologist told her he couldn't treat her anymore with blood transfusions. I'm not saying that that's a great treatment, but what I am saying is there are ways around the dangers of blood transfusions. There's artificial blood, there's plasma expanders, a whole bunch of things, which no one unfortunately has looked at yet. You can improve the blood volume a little bit with fludrocortisone. This was a study that Peter Rowe did in 1994. It works best on kids. It doesn't work very well on adults. And it doesn't work well enough to, for people to be using it now. It's interesting, but again, the only thing it does is it holds on to salt and makes the blood volume expand a little bit. So I used to treat my patients routinely with fludrocortisone to see if they happen to get a response from it. You can use vasoconstrictors, which many people will do, and I don't think that's a great idea. You can give them normal saline infusions, and that's something that I did a lot. If somebody went into a very bad relapse and you gave them 2 or 3 days of normal saline, they would have a marked response, and they'd do much better. Now, the most severe patients with ME/CFS, they do not respond to normal saline, nor do they have reduced blood volume. That's a mystery that no one has looked at, but there's no question about that in my mind.
I'm wondering if the findings of David Berg of Hennick's lab, where he found high fibrinogen levels in CFS patients, is related to this?
I don't think so. I think that his findings were correct, but it wasn't that those patients were bleeding out. If they were bleeding because they didn't, because they're fibrinogen, they would be able to have high ADH. They'd replace their volume very quickly. So I understand what you're saying, and I've thought about it. Normal persons have less than an 8% variability from one day to the next. Sedentary controls also had a low variability. People with psychiatric illness have no variability, low variability. So you can be crazier than a loon, and your test would be the same one day, the next day, and every day thereafter. However, in ME/CFS patients, you have a drop of what's called the anaerobic threshold up to 40%. And this is an unimaginable drop. Here's what happens. This is day 1 here. The blue is the VO2 max. I hope none of you are getting nauseous because I've got a tremor here. Okay, the blue is the VO2 max, and that goes like this. You're breathing into a tube, and you're measuring oxygen and carbon dioxide. So the VO2 max goes like this, and at the same time, the carbon dioxide you're breathing out goes like this, and at a certain point, it crosses. That's called the anaerobic threshold. The anaerobic threshold is where your body goes from functioning on oxygen to functioning on not oxygen. So let's say you're a runner and you run the 400-yard dash. the first 350 yards, you can utilize oxygen quite nicely and you're running like crazy. The last 50 yards, you go into anaerobic metabolism and you're just struggling to make it across the finish line. It's agony. You hurt, you can't breathe, you gotta do this. You make it across the finish line and you collapse. So that's the anaerobic threshold which every one of us has. Now, in people with who are couch potatoes, their anaerobic threshold's a little lower than athletes who are up here. But it doesn't change easily. If you are measured, and you're right here, and you take on an intense fitness training, you can raise your anaerobic threshold over up to here in 6 months. I mean, yes, it can be changed, but it takes a long time of really dedicated work in order to achieve this. But here's where you are in your anaerobic threshold. Now, on day 2 for people with MECFS, their O2 max, not quite as high, but not bad. But what their carbon dioxide crosses here, and this compared to this is averaging 40% less. And that means that people who have MECFS cannot maintain oxygenated or oxygen-based metabolism. When you are doing oxygen-based metabolism, you feel pretty good. Let's say that your normal activity is you like to jog 2 miles, and you're a healthy person and you do that. Every day you can jog 2 miles. A person with MECFS on day 1, they can jog 2 miles. Not well, but they can do it because they are at their anaerobic threshold. However, something about doing that activity causes them to crash, and their anaerobic threshold drops 40%. And then they can't even get out of bed. This is the post-exertional malaise, and it's probably the most important hallmark symptom of the illness. And it's something that was strongly emphasized in the Institute of Medicine report. This 2-day exercise test cannot be reproduced if you're crazy. So a lot of people will have a lot of self-doubts. You know, maybe I'm a fruitcake. You know, maybe that first doctor hit it right on the head and I'm a complete fruitcake. But if you were a fruitcake, you'd actually not have post-exertional malaise, and you'd still be a fruitcake, but your anaerobic threshold would not change. So this illness is not due to psychiatric factors, and this is a conclusive proof.
I had this test 3 years ago, and I just want to say that they also told me that you also can't fake this. You can't fake this. They told me that you can't fake this result.
That's right.
That there are people who, for whatever psychiatric reasons, want to fake an illness, then get sympathy and all that. You cannot fake this result.
That's right. This is how your cells make energy. So you're either making them through aerobic metabolism or anaerobic metabolism. And there's no way you can consciously affect that. This can't be faked. Basically, if you're interested in applying for Social Security disability, you need to have a test that proves that you can't work 8 hours a day, 5 days a week. This is it. I mean, very, very straightforward. I've argued that in Social Security disability cases on several occasions. A 2-day exercise test.
It's also known as a CPET, cardiopulmonary exercise test, 2-day.
Right.
Who gives this test?
There are a number of exercise physiologists that will do it. In New York, there is an exercise physiologist named Betsy Keller at Ithaca, and she's superb. She learned it from Stacy Stevens out here at the University of the Pacific, and Stacy Stevens still does that. So, you know, this is a test which is very useful. However, a word of warning. If you find that going out and getting the mail will put you in bed for a day, you don't want to do this test. If you have that level of severity, the first day of exercising on the bike, where you're really pushing yourself to do it, may knock you down for a long time. I've had one patient who never recovered. How'd you do?
It made me ill for a month.
Ill for a month.
I couldn't hardly move for a month.
So if you have this test, get a liter of IV saline immediately after the second one. That'll help.
I had the test too. Stacy's no longer at University of Pacific. They're at WorkWell Foundation now. Same Sacramento area. And I had it and they gave me the saline and it was a huge difference. I can tell.
They've also done one patient who had the test before saline, and then after, I don't know, 4 months of IV saline daily, and it was quite different. IV saline does something to this mechanism. I don't know what that is, but it helps. Okay, natural history of the illness. 30% of patients in a community outbreak, like what happened in Lindenville, are children. Their prognosis is probably better initially, meaning in the first 3 years. But as soon as they get to be 35 years of age, they go downhill. And this is something that has been very tragic, and it's been clear. I took the 60 kids in the Lindenville outbreak and I studied them at 5 years, 15 years, and 25 years. So used the same instruments and was able to measure their severity. And at 5 years, they were not doing very well. At 15 years, they were doing pretty good. They were coming up. At 25 years, they were all really crashing. And none of them can find physicians. They have the problems that you know all too well. And it seems that at around 35 years of age, that's when things start getting worse again. Adults, the severity is predicted by the severity at onset and the severity of the neurologic symptoms. If you have neurologic symptoms that are really nasty, you're going to have ongoing problems. If your cognitive symptoms are really bad, or then you're in for a tough time. Very few people completely recover. I think consensus now is saying that 5% of patients completely recover. And the other 95%, many of them do quite well, but they're not 100% recovered. They still have traces of the illness. Most improve, but a good 10% of patients with this illness are on a steady slope getting worse and worse and worse. I recently gave a talk about those people who have died from the illness, and that happens. So while the CDC says it doesn't happen, they're wrong. If you ask any clinician who spends their time seeing this, there are some patients that will have a steady deterioration and can pass away. Treatment, very controversial. Some people say if you treat the infection that initiates the illness, you can improve the illness 50%. Jonathan Kerr said this in 1994 because he was studying people who got sick after a parvovirus B19 infection. And he treated them, the ones that he knew had parvovirus B19, he treated them with gamma globulin, and they did well. They did better than the average. So, does exercise help? Yes, but you have to monitor your exercise by common sense. If you go out and start doing a little walk and you start feeling sick, tired, stop. Don't go any further. If you take a walk and you're feeling kind of invigorated, tired, great, wonderful, take the same walk tomorrow and slowly increase. But listen to what your body's telling you. Exercise is not going to change the anaerobic threshold. In fact, it's going to make it fall down. But there's a certain point where people will say, you know, I can do more now than I could last year. And should they do a little bit of exercise? Yeah. But we're talking a little bit. Maybe some yoga, maybe a little this, a little this. B cells make antibodies, which means a possibility. One, the virus that causes the disease lives in B cells. You kill off all the B cells, you no longer have that virus. That's one option. Option two, the disease is caused by interleukin 10. Interleukin 10 is made by B cells. You kill off the B cells, maybe that's why they got better. Or number three, they have an autoimmune disease where they're making autoantibodies against a vascular component, and that's why they have vasoconstriction, poor blood flow. You kill off the B cells, that antibody disappears, and you get better. So lots of work to be done on this, and also to find out what happened to the other 36%. A lot of work to do, but this is something that's very exciting. And that's it. So,
I just have a quick question going back to something. The 5% that maybe recover, I mean, since there isn't a lot of testing done yet, could it be that those 5% don't even really have seed or CFIDs or Icelandic seeds, whatever you want to call it? Any?
yeah, but I don't think so.
You don't. You do think that 5% might actually recover?
Oh yes.
Yeah. Oh yeah.
Yeah. That's something that I've looked at very intensely over the years, and I wanted to know what did they do that was different that caused them to recover. Did they exercise more or less? Did they take more vitamins, less vitamins? Did they eat better? Now, Lyndonville is a very small area, and I was the only physician in the area, so I kind of had a lock on these patients. And I was nice to them, you know, I tried to be nice. And after looking at this, about half of the patients ate terribly. You know, they get a McDonald's every once in a while, and the other half ate meticulously, very good foods, and I didn't see any difference. Half of them had lots of vitamins, half of them did not. Half of them, so I couldn't tell. But what I was quite sure about was that they had the same illness. So I had lots of ways of measuring the severity, measuring the complexity of the symptoms. For example, I was very intent on measuring the degree of lymph node tenderness. That's an unusual symptom. So that if you have rheumatoid arthritis, it's not one of the things that would happen. So I'm quite sure they all had ME/CFS. And there was a subset that clearly did get better.
But you never had any, even like inkling of maybe what it was?
Not an inkling. Yeah. And believe me, I listened to everybody who said, people would send me the craziest theories. I got these letters from a guy in England who said the reason Lyndonville people got sick was because of the aluminum in the soil, and so after about a year of his letters, very detailed, very complicated, I finally said, you know what, don't write me anymore. I've learned a lot about aluminum poisoning, but I don't think that that's what it is. But people told me their theories, and I would always listen carefully. Yes?
How do you account for the, I guess, they is the lack of research being done by the federal government, for example, or any other hospital or entity? Is it because the numbers of people that have this are too low for them, or what?
The number of people that have this illness is extraordinarily high. My guess is 2% have it, although maybe 0.5% have it so mild that you can't make the diagnosis. But 2% of the population is a huge number. There are two factors. One is there's no money to study it. So I have friends down in Ithaca who are writing research grants all the time, and they always get rejected. And you know, they're good and interesting grants. So that there's no money. If you don't have money to study this, you're not going to study it. It's really very simple. The study will follow the money. What happened with AIDS, which came on in 1982, is that all of a sudden ACT UP started pouring blood on the steps of the Capitol, and the money just came. Oh, and now look at AIDS. Nancy Klimas has a clinic where half of the patients have AIDS, half have chronic fatigue syndrome. The AIDS patients, she calls hale and hearty. They're doing great. You know, they have these different treatments, and they're functioning well. The ME/CFS patients are doing terrible. So the money is the first thing. There will be no researchers getting interested in studying this illness unless there's money to pay for their research.
Why is there a problem with the money? I know this organization tries to mitigate that, I think, a little bit. And there was some publicity about the National Health Institute committing something to this. But why is it so low? Because it's not dramatic enough for them?
Well, because people don't die frequently. You know, there are a few that will die, but this is not a fatal disease in general. And the people that have this illness in a severe form are too sick to do anything. I have 3 patients who were bedridden when I retired, and none of them have a doctor that will see them because they had to be seen in house calls. And you know, they have no medical care whatsoever. They have insurance, but no medical care. And that, I think, is a tragedy. But, you know, to answer that question, why is this such a horrible situation? I don't know. The politics of this illness have always escaped me.
Does the Social Security Administration at least recognize the illness, and all you have to do is prove certain things, or are they into denial also?
There were a few years I was chairperson of the Health and Human Services Advisory Committee. And sitting at the advisory committee was the head of Social Security, the head of FDA, the head of CDC. And there was one meeting where the head of the Social Security Administration got up and said, he said, you know what, we've made great strides. This year, we have granted Social Security disability to over 21 people. and everybody on the committee, we just went, they don't understand that the only way to get Social Security disability is to say, I'm crazy. I can't work, you know, it's too bad. I'm completely crazy and I've got bad back pain. And then, oh, okay, yeah, no problem, you can't work. But if you say you have chronic fatigue syndrome, you have to prove it. And how can you prove it? Well, you can do the 2-day exercise test. Is that listed in the tests that are accepted? No. There are probably 10 different tests that are usable for proof. But Social Security says you have to prove your disability. And it's a tragedy. So I do a lot of Social Security disability, or I used to, and it's very easy. What I would do is I would say, Mr. Jones fulfills the criteria of the Institute of Medicine. He has this, he has this, he has this, and he can't work. And they have to prove the Institute of Medicine wrong, not me. Now, if I say, I think he's got disabling condition, they can say that I'm crazy and they won't pay any attention. But they can't argue with the Institute of Medicine. But doctors don't like to do this. You know, this is not their job, writing reports for disability. And it's very hard to get any physicians to do this. I think there should be clinics, multi-specialty clinics, and one person in that clinic should be in charge of doing disability. The number of people who are actually disabled by this illness is enormous. And Social Security is paying them disability insurance. Now, they think it's atypical MS, or they think that it's a psychiatric disease, or whatever. But if they realized how much they're paying for MECFS, that would get people moving.
And two, it seems like in our community and many other things that I've read, that a lot of people get treated with this but end up being worse afterwards.
I was very careful about making sure that the patients I treated with different things understood what they were getting into. And, you know, I'd say, you know, I really hope this medicine doesn't kill you. I haven't killed anybody yet, but, you know, we're just going by the seat of our pants. We just don't know what we're doing. So that you need to have good informed consent. And yes, it seems like just about every treatment I've heard about will have some people who will be worse because of it. Secondly, antiviral treatments. If you have, like in the Stanford's first study, an antiviral treatment for the initiating infection, they seemed to look like they were doing pretty good. You know, they were very hopeful that they had stumbled onto the answer. But then the second study didn't quite bear up to that. So treating with antivirals, I think it's a wonderful thing. In my way of thinking, there were certain patients that needed to be treated with weird stuff. There were a number of patients that would like to be treated with something. And there were a number of patients who you couldn't treat. You know, if you suggested aspirin, they'd say, no, I'm not going to do it. And you have to honor that. So, you know, the patients that I would treat with different things, I made sure that they understood what was going on. And they understood the results of their tests. If a clinician does a lot of tests, doesn't share the results fully, and then expects their patients to just do whatever they say, that's not really going to work too well. The problem with that is that it takes time. And, you know, as they say, time is money. I was lucky, I was the only doc in the town, and I could spend whatever time I wanted. But in the modern medical world, you get 15 minutes.